So we'll talk about T790M positive acquired resistance. This is the pie chart you've seen earlier. This is a pie chart that we made a couple years back based upon biopsying about 125 patients who had been on gefitinib or erlotinib, progressed, and then they agreed to a biopsy of their tumor. And this is what we found when we biopsied their tumors. And I think the big green part is the take-home message that the majority of patients had T790M as the mechanism of resistance. Sometimes it was by itself. Sometimes it overlapped with some other things like HER2 amplification, MET amplification, small cell transformation, things like that. But T790M itself is really the driving factor. And this was actually identified as a mechanism of resistance all the way back in 2005. So we first discovered EGFR mutations in 2004, but kind of immediately people set up to figure out why resistance happened, and they figured out this T790M back in 2005. So it's been known for a while, but what's taken a lot longer is translating that into treatment for people. And so I'll just show you just a little bit about managing resistance. I think we've talked a little bit earlier about the notion of the brain as a separate area, and that we kind of have different approaches that we take for patients who have brain-only disease or brain-only progression. And the rest of the time we think about whether a tumor is T790M positive or negative to guide us. So, as I mentioned earlier, 2005 is when these mutations were first identified. It took a few years. Actually, the first reported finding of a drug that could target T790M was from an academic laboratory. This was from Pasiani at Dana-Farber Cancer Institute, put together a chemical screen, where they looked at thousands and thousands of molecules and found a drug that could actually inhibit EGFR T790M. It was a major breakthrough. There ended up being some legal challenges as to why this drug didn't move forward, but the knowledge of this structure led a number of drug companies to look at catalogs of drugs that they already had and find drugs that were like this. And subsequently, folks developed drugs in people and did phase 1 trials. And the two lead candidate molecules are these two drugs. One is Rociletinib, used to be called the Clovis drug, and CO 1686, and the other one is AZD9291, or Osimertinib. The expectation is that both these drugs will be FDA approved in the next few months. They're not there yet, but I think that's the expectation. I would just say that the uniting factor for these drugs is that they're developed to target mutant EGFR, particularly T790M, and then spare normal EGFR. So one of the side effects, the main side effects we think of when we target EGFR are rash and diarrhea. These are thought to be a consequence of hitting regular EGFR, normal EGFR. And so if you can make a drug that doesn't hit those, then you'll actually have fewer side effects and greater efficacy. These two drugs are both thought to target this. I'll talk a little bit more about the toxicities in a second. I would say that the Rociletinib tends to have a bit more blood sugar problems, so diabetes that develops in people on this drug. The 9291 might have a bit more in the way of rash and interstitial lung disease, but again, I'll show you that more in a second. This is a slide Karen actually used earlier. This puts these drugs into context to explain, what the drugs are targeting, because sometimes we talk about T790M drugs and people think these are drugs that are just hitting T790M and not hitting the other EGFR mutations. But in fact, the newer drugs, Rociletinib and Osimertinib, both target T790M as well as the LA58R or exon 19 deletion, just as well as afatinib, erlotinib, and gefitinib do. So why we care about these drugs is because they do have some activity. And so this is a waterfall plot. You guys have seen a few of these, but I always like to point out kind of what we're looking at here. Each of these bars represents an individual patient and their best response to therapy. So this patient all the way out here had 100% tumor shrinkage, whereas this patient out here had 45% tumor growth. We want our waterfall plot to have kind of this shape to it. But what we see, the take-home message from this is that AZD9291, osimertinib, does shrink cancers significantly in about a half of patients. And this is a group of patients who had resistance, and this data isn't particular to whether they had T790M or not. This is the clinical resistance situation. If you separate out only those patients who have proven T790M, the numbers look a little bit better. So the response rate jumps to 60%, and the waterfall plot shows a bit more in the way of tumors shrinking and a bit less tumors growing. So this is, this does support the idea that this is a T790M specific phenomena. Just to show you, though, that while the numbers are similar, there's clearly much greater benefit for patients who have T790M than those who don't. This is osimertinib, and these are the progression-free survival curves. So time until the cancer grows for individual patients, and you see that for patients who had T790M positive disease, if you follow out the median point, about 9-10 months, people are on average having good disease control. In contrast, if patients did not have T790M negative, it tended to control disease for 3 months or less. I mentioned side effects earlier. This is the side effect graph for AZD9291 for the 80 milligram dose. The relatively impressive thing here is that there's very little, almost no grade 3 toxicity. Grade 3 in our lingo, grade 1 is mild, grade 2 is moderate, and grade 3 are severe toxicities. So very, very few severe toxicities. But the toxicities that people do have are the ones that in Tarceva treatment we kind of get used to, things like diarrhea and rash, as well as things like nausea and poor appetite that may or may not be directly related to drug or may be related to the disease itself. But you'll also recognize some of the other side effects that are very classic for Tarceva. So paronychia, which is these infections around the nail beds, and then skin itching because you have dry skin. So the other drug, Rociletinib, or CO1686, this is the waterfall plot for patients with T790M. Again, you see a response rate around 60%, very similar to the plot that I showed you for patients with AZD9291. Treated patients who had T790M treated with AZD9291, and similar response rate, similar shape to the curves. This is the the table of side effects for Rociletinib, and again, similar grade 3. Very, very few grade 3 toxicities, with the exception of one, and that's hyperglycemia. So diabetes happens in some proportion of patients. So in this data, about 20% of patients who got Rociletinib developed diabetes. This is not the sort of diabetes that typically is treated with insulin. It's typically treated with pills that does a pretty good job of managing hyperglycemia. I have to say I've had a few patients on trials related to this, and after either dose adjustment or starting a pill called metformin, patients generally do well. So I think all this sounds like a scary thing. It's quite manageable on a day-to-day basis. So Leora showed this data a little while ago, and I wanted to go over it again because I think it's really important. This is some data that was presented at ASCO this year, and I think it looks at this idea of how you define whether a patient's T790M positive. So we know that T790M is found in 63% of biopsy specimens. I told you that. But there's really heterogeneity in the different sites for an individual patient. You biopsy multiple sites, you get different answers. What does that mean? And so one idea is that the plasma can sample multiple sites of resistant disease, making that maybe the gold standard in terms of determining T790M status. So this is the data you saw earlier. It's kind of at a slightly different form. What you see is that if patients had tumor biopsies that were T790M positive, in this set of data, the response rate was 53%. If they had plasma that was T790M positive, it was 53%. if their tumor biopsy was negative for T790M, but plasma was positive for T790M, it was 37% response rate. And to me, a little bit more intriguing data is the results when you had patients who did not have T790M on the tumor or in the plasma, and the response rate was 27%. This is a very small bit of data, and I think it's likely the FDA is going to require or label this drug to be for patients with T790M. But I think if that response rate holds up, and it's superior to response rates we see with chemotherapy, superior to response rates you see with immunotherapy, maybe the role of T790M biomarker in this setting is not so concrete. So how are we going to do treatment going forward? I think for the people in this room, the initial treatment decision was already made for the most part. But when we go forward and when Jack and I meet new patients who have newly diagnosed EGFR mutant disease, how are we going to deal with that? Are we going to go to one of these newer generation drugs as the first treatment, or are we going to wait till later? And I think this description is kind of how we approach it today, where we give patients initial first-gen or second-gen EGFR TKI, so Iressa, Tarceva, or Afatinib. And then when they progress, then we will move them to a third-generation EGFR TKI. But another approach that might make sense is to just start with a third-generation EGFR TKI, maybe with less toxicity. It might be even better side effect-wise, and it might be last longer. We don't know if this is the right answer, but we're starting to get some data on this. This is some data that was presented at ASCO this year. This is not a randomized trial, so they didn't compare standard Tarceva to initial AZD9291. They just took a whole bunch of patients who were initially diagnosed with EGFR mutant lung cancer and treated them with AZD9291. And what we saw in really thinking about the standard dose arm, which is this arm here, is that at a year, 75% of patients had not had the cancer grow yet, which is a little bit higher than what we expect to see with patients on Tarceva or Afatinib. And so as a consequence, I think this may have maybe a reasonable approach, but it really requires some randomized trials for us to know this for sure. I'll skip over these because I think it's probably not particularly relevant, but I would want to emphasize that these are not the only drugs in town, and these are just a couple more that are recently in development. One's called EGF816 from Novartis, and one is ASP8273 from Astellas. These are other next-generation EGFR TKIs. We don't know as much about them in terms of their effectiveness or their side effect profile, but this is to suggest that there's a lot going on in this area, and I think we have a lot of exciting days ahead of us. So just to summarize, Rociletinib and Osimertinib are drugs that are likely to significantly shrink tumors in patients with EGFR mutant non-small cell lung cancer with resistance to Gefitinib, Erlotinib, and Afatinib. Understanding T790M status of patients is complex, and given the heterogeneous sites of disease and sampling effects, both biopsies and blood, it may be important to think about plasma-based testing. Finally, the first-line data for both Osimertinib and Rociletinib is immature, but it looks intriguing. So I'll close there and let Jack take on the harder topic.